We are finding ourselves wrapping up Breast Cancer Awareness Month, and we thought it would be nice to answer some questions about women's hormone replacement therapy, estrogen, and breast cancer, because we take care of a lot of patients with hormone replacement, hormone balancing, and it's probably the most common question we get, right?
Absolutely.
Does estrogen cause breast cancer? I have a family history of breast cancer. I had breast cancer, and it's my understanding that hormones aren't appropriate for me. And so we wanted to kind of delve into that a little bit more and maybe answer some questions for you that we are asking and answering for our patients every day. And Susan, does this daily and has a really great grasp on some of the history of how we got here. Why is this even a question? So I don't know, maybe Susan, you want to start and talk to us a little bit about what's the history of estrogen, hormone replacement therapy, and breast cancer?
Yeah, thank you. We've been using hormone replacement therapy for women since about 1933, which was actually kind of a surprise for me to be reminded of. We started with a product that we used from pregnant women's urine, and they were able to extract estrogen from that. And through that, we were giving that to women for about a decade until the production became a little too costly. They looked for an alternative, and it was found that we can extract estrogen from pregnant horses. And from that study and information, we developed a product called Premarin, which is still on the market today, is not used very much, but still available. And that is where the name even came from, pregnant mare urine. That was used since the early 1940s into the 1970s exclusively. So we were just giving women this horse estrogen that has a little bit of a component of a natural human type estrogen in it, but also many other estrogens that are not meant for humans. That continued on until the early mid-70s, when suddenly we were starting to recognize that there was a big uptick in uterine cancer in women. And that really scared off a lot of people appropriately. Prescriptions went down, the use of it went down, and it was discovered, hey, we're missing the other hormone, and it was a product called medroxyprogesterone was added, a synthetic form of progesterone, and that was back on the market and being used. Flash forward to 1992-ish, a huge study was developed and initiated called the Women's Health Initiative. And this study used about 65,000 women, I think they used in that study. And it was going on, and I won't get into all the details, but essentially in about 2002, we started seeing an uptick in breast cancer in women. And that's where the real scare started. And pretty much overnight, I had just started my PA career about 2 years prior to that. I was in a breast surgery practice. We just wiped it all out. We took women off estrogen overnight, and a lot of women were very miserable after that. That maintained for many years until we really started recognizing, let's reevaluate this study. And so over the last 10, 12 years maybe, more and more people were reevaluating this, and what was really determined that even the Premarin arm of it, the horse estrogen arm of it, was actually healthier than not being on hormones, and it was the chemical form of progesterone that was really the culprit in raising this risk of breast cancer. Interestingly, it wasn't even that high of a risk, but it was enough that it really shut down things. So we started bringing back bioidentical hormones, which we'll talk a little bit more about. And that's where we are today. And even as recently as this summer, July, there was a large FDA panel of experts that sat down and really lobbied to say, we need to make some changes in women's health here. First of all, there's a cancer scare on these medications. They are even on the topical estrogen that we use vaginally that doesn't even get measured in the blood. And it's really a call for, hey, time for a change. So that's where we are now. And now in 2025, almost, too long, that we really need to come back up to date and figure out what are really the causes of this cancer, and is it really this compound that you and I and all of us have made naturally throughout our lifetime.
It's interesting in that while the FDA panel they had a lot of women on the panel. First of all, like a woman orthopedic surgeon, a female endocrinologist, and the entire panel, the bottom line was they said, we have to stop harming our women by not allowing them access to hormones. But this whole scare of estrogen causing breast cancer, as Susan mentioned, it wasn't even the artificial synthetic estrogen that was causing a problem. And in some aspects, they felt that that was either a non-contributor, certainly a non-contributor to breast cancer, but still even breast protective. And it was really more the artificial synthetic progestin that was causing problems as far as heart disease, increased breast cancer, clots, strokes, and all of these things. So it wasn't even really the estrogen that was the issue, but it was the artificial synthetic progestin that was a problem. And you have to be careful in naming things, because there was some point where people would say, well, it doesn't matter, it's all the same. And it's not the same. Just like you have a key that fits into a lock, if the key isn't exactly made to fit in the lock, it might fit in there, but it's not going to activate your lock. Like, we've all had that experience. Hormones are keys that fit into receptor locks and activate the cells. So progestin does almost exactly the opposite of progesterone, which is the true hormone that we make in our bodies. So whenever we're looking at these studies, you have to know, when they say hormones, you have to know whether they're talking about Premarin or the horse-made estrogen. Is it really human or bioidentical hormone? And is it progestin or progesterone? Because they're very much, in that case, really almost opposite in terms of what they do. So that makes it hard, I think, as a lay person to evaluate the studies, because we don't even know oftentimes which hormone that we're talking about.
And furthermore, they even name them very deceptively. So the progestin that we're talking about, that is kind of the bad actor, its technical name is medroxyprogesterone. So if you don't really know how to interpret that, that looks like just another form of progesterone, where that's the synthetic bad guy. And I think a lot of that is just deceit in marketing, personally. you know.
It's interesting, this women's health initiative. So it was on the cover of Time magazine in 2002 saying that hormones are harming our women. And that's when, as Susan mentioned, almost overnight, the prescriptions stopped. Women didn't want it, doctors didn't want to prescribe it. And a lot of health harm started at that point. So increase in colon cancer, increase in heart disease, increase in fractures. All of these things are the things that harm women ultimately. And so it's interesting because they actually carried out that study, continued it for over 20 years. And what they found, and this actually got published but did not come out on the cover of Time magazine, is that, it really didn't affect women in that way. And so there was kind of a rebuttal from the principal investigators of the Women's Health Initiative study that came out in a paper that said all of these things that we said were harming women actually turned out to not be statistically significant, like they didn't matter. But nobody rebutted this publicly on the cover of Time magazine to essentially say, never mind. It wasn't like all these things that we said earlier on did not actually come to fruition. So a lot of harm has been done, and now we talk about what are the side effects and the complications from doing hormone replacement therapy, where the question really should be, what are the harms that we're causing women by not doing hormone replacement therapy?
And especially in cognition, women 2 to 1 get dementia versus men. And a lot of that is the decline of estrogen at the minor risk of getting a breast cancer, which will not more than likely kill you. So we've really, just as Dr. Atagi said, really just flipped it over and said, let's prevent this, which barely happens, honestly. Other reasons, certainly, it's not that breast cancer doesn't exist. And then we're going to offset that by more heart attacks, more cognitive decline and dementia, more hip fractures that do end in death for a good 25-35% of women that have a hip fracture within a year.
So one of the experts on the FDA panel, the orthopedic surgeon, she said 50% of women do not recover from a hip fracture. And I think the number was 20% or greater will die
Absolutely.
from some complication of having a hip fracture. And if you talk about betting on the odds in Vegas, you're more likely as a woman to die of heart disease than you are breast cancer. So they talk about statistics like 90% of breast cancers these days are curable, or you're not going to die from your breast cancer. But heart disease is the leading cause of death in women, still, men and women. And it was interesting. So they talked about what is the risk of breast cancer. So I think the number that all of us women are familiar with is that 1 in 8 women will, in the U.S., will develop a breast cancer. But what's interesting about that is if you look at your risk of breast cancer at a particular age, like the second decade of life, the third, the fourth, the fifth, the sixth decade, the cancer risk, for example, I think it was if you're in your 60s, is 4%. And it's 3.6% in the decade before that. So what they've done is they've added up all of those percentages to get a total that says your breast cancer risk is 1 in 8. That is not true. The breast cancer risk is actually much lower than 1 in 8 but it depends on which decade that you're talking about.
And then we add on what's the pathology. So in those breast cancer diagnoses is something that we call infiltrating duct carcinoma. That's the type of cancer that can spread to a lymph node, can become metastatic. There's another poorly named diagnosis called ductal carcinoma in situ that many pathologists now recognize not really a true cancer. It's confined within the ducts, will never spread, but still gets treatment as far as, not inappropriately, getting rid of it, but many women may have radiation therapy after that, and then they are told not to have hormone therapy when they didn't even really have a true breast cancer. So again, it's the definition, the time frame, individual people, what is really the whole picture, and not just 1 out of 8 women get breast cancer.
Right. Well, and I think too, people talk about, so again, as a lay person, I think it's hard to read these studies and be able to make sense of them. But there's also a practical theory that talks about, well, what is the cause and effect of something. So, you have to have exposure to something that causes something else. It has to have a strong correlation, these types of things like lung cancer to smoking, there is a correlation there. When you talk kind of about the practical aspects of it, if you look at things like saying, okay, estrogen causes breast cancer, well, your breast cancer risk only increases after menopause. So that means you have the least amount of estrogen circulating when you're at the highest risk of getting breast cancer. And when you're pregnant, your estrogen levels go up by tenfold. Well, for patients that have actually been diagnosed with breast cancer during a pregnancy and have had their pregnancy terminated because of their concern of the breast cancer, their prognosis doesn't change at all from having terminated the pregnancy. So, from a logical standpoint, you would say, okay, well, if you have exposure to something, the greater the exposure, the greater the bad outcomes or the greater the potential risk of having or developing the cancer. Those things don't correlate, they don't match up. And why would something that your body starts to make before you're born cause a cancer all of a sudden? It doesn't. So there are some of these very practical, logical sorts of things that have come up that don't make any sense.
That's a really excellent point, because so many women, especially that cohort that lost that opportunity to have estrogen for their menopausal years, many of those women are today in nursing homes with dementia. And furthermore, if they got a breast cancer, many of them were never even on hormone therapy. So they're not on hormone therapy. The next generation, their daughters are being told, don't have estrogen because your mom had breast cancer. But essentially they're saying, do what your mom did, don't go on hormones. And their mom got a metastatic cancer. And you're like, well, where's that makes sense? So we really need to revisit this whole picture, because it's this next generation of women in their 50s, 60s that are really going to get a disadvantage from the other health benefits, when it didn't even make sense to make them, ineligible for it based on the fact that their mother didn't even have this treatment. And so, yeah, that's a really frustration that we've kind of lost some of our critical thinking about this.
Right. For example, we get asked, well, what do other factors have to do with breast cancer? Things like obesity or diet.
The diet, the sugars specifically.
And all of these things have a much bigger impact on feeding and growing and causing cancer than something like estrogen, in which has in some studies been used to treat breast cancer, high doses of estrogen. And so if you look at obesity, for example, so why is it that patients that are heavier have potentially more aggressive cancers or worse prognosis? Well, if you look at women going through menopause, you lose estrogen and testosterone. So you're losing some of the protective effects for bone, brain, heart, things like that. So what does your body do? It tries to make more estrogen somewhere else. So unbeknownst to a lot of people, fat cells make estrogen. So if you think about women who go through menopause, we tend to gain weight, right?
It's a protective measure.
Yes.
It's trying to give us more estrogen.
More estrogen. But the problem with it is that your body makes 3 types of estrogen, right? It makes estradiol, estriol, and estrone. So estrone is actually potentially cancer promoting.
Right.
So it's the one of 3, the one bad form of estrogen. But your fat cells tend to make more estrone than your ovaries do.
Exactly.
And so, so that correlates, right? It makes sense that if you're heavy, that you could have potentially a worse form of breast cancer or a more aggressive form or have a worse prognosis, because you're making estrogen from your fat cells, which tends to make a higher ratio of the bad estrogen.
And most people that are obese have poor diets, so they are feeding this with ultra processed foods with all the additives that are in there. I really do not advocate American wheat. American wheat has numerous pesticides in it, specifically atrazine. Atrazine is known to feminize male frogs. I'm not sure that's not doing something to women. So this whole diet thing is really sugar related, food additives, contaminants, and that is also another piece of adding to the obesity, and then you do get this metabolite that's much more cancer feeding.
Well, and when we talk about sugar, so why is sugar bad? So when you have cancer, they use a tracer, a radioactive tracer, that's attached to glucose when they do your PET scans, because sugar feeds cancer. So that's how they're looking to find your cancer. Has it spread? Is it growing? Where is it? Is they use a radioactive tracer attached to sugar water that they put into your IV when you're doing your PET scans, because the sugar is going to go to your cancer. Let's not forget that sugar feeds cancer pretty aggressively.
And that's why so many people can offset their cancer by going on a more clean diet, ketogenic diet, really getting rid of the sugars, because cancer can't feed on a ketone, but humans can very effectively. And the diet part of all of this is really being underplayed.
Yeah.
And the other contaminants that are in our world.
Well, and just since you mentioned ketones, so this FDA panel, the endocrinologist on the panel, talked about dementia as being type 3 diabetes. And I hear that a lot these days, and I didn't really understand the physiology behind that. But a lot of us know about the keto diet, right? Why does a keto diet work, and why is it called the keto diet and all of that? So basically, the primary energy that your cells use is glucose or sugar. And so sugar needs to get into the cells. And so when you go on a keto diet, you're not eating sugar. So your body's looking for its next source of fuel, right? So it starts to burn fat or muscle. And so when it burns fat, it makes what's called ketones. And so if your brain cells don't have access to sugar, it does the same thing, right? It looks for its next fuel source. So it's looking at fat, and there's no muscle in the brain. So it's interesting because your body is literally burning or eating its own brain as a fuel source. So what does that have to do with hormones? Well, estrogen and testosterone help to make your receptor or the lock on your cells sensitive to insulin. So if you don't have estrogen and testosterone, it's very hard for the insulin to work, to activate the cell, to allow the sugar into the cell. So you might have this receptor, and if it's not working, like the insulin can't open up the cell to allow the sugar in, then it literally starts burning the white matter or the outside myelin sheath or the coating on the outsides of your brain cells. It's literally eating the fat or its own brain as fuel. So men tend to develop dementia less often and later than women. So when women go through menopause, you don't have that estrogen and testosterone brain protection any longer. But men make estrogen from their testosterone. So even if their testosterone levels are low, they have some degree of brain protection because they're still making estrogen. So that's one of the reasons that there's discrepancy in terms of when and how often men and women develop dementia. Is when women go through menopause, you lose the brain protection.
Yeah. The other things that can really affect developing cancer is pretty ubiquitous around us, and those are the microplastics. And again, the chemicals, things like BPA. You know, we kind of, little buzzwords out there, but I don't think most people really know how much plastics we really ingest. You know, you take a can of soup, it's lined in plastic. Literally, you can dissolve the outside of it and you can see a sack sitting there. That's with every can out there, whether it's soda, whether it's food, unless it says BPA free. Most register tapes that you get at the grocery store or at a store, unless it's a laser printed, it's BPA. So if your kid's working at King Soopers, they are constantly touching this register tape and getting that into their body. Those are the things that mimic our hormones, specifically estrogen. So now you have a compound that is just kind of everywhere around us. In our Starbucks cups, you put a nice hot cup of coffee in there, the plastic's melting, we store our food in plastic frequently, we microwave our food in plastic. That goes in your food. Those things get into your cells, and now they block and fit in the estrogen receptor. So you actually get a chemical that's mimicking the growth factors of estrogen. We have, you know, not uncommon, young girls are 8 and 9 years old and now for menses, for getting their period. The average age in America right now is 12. You know, in my age, and I'm, you know, in my late 60s, it was 14, 15 was very common. So those are the things that now block this estrogen receptor, pretend it's estrogen, and avoid or block your own estrogen from getting in there. And then it messes up the whole system with your progesterone, your other hormones. So we really don't recognize how many of these factors are going on, because that's just our life, and how bad can that be? And we keep going back and blaming the hormone that actually our own body made to begin with, when really it's these chemicals that are doing that.
Well, and to your point, you know, why can't you recycle a cardboard or paper Starbucks cup? Because it is coated in plastic.
Exactly.
You know, that's why you can't recycle them.
I forgot about that. You're
So,
right.
and I think we've all probably seen, you know, the mention of finding microplastics in our bloodstream now. So,
Yeah, they're all tissues that they've tested, as far as I know. And, you know, if they're getting into, you know, things like testicles, now you actually have physical compounds taking up space where sperm are supposed to be. I don't know that I've seen a study with respect to ovaries, but I can't believe that that's not affecting that as well.
sure.
Yeah.
I'm just looking at some questions that we've gotten from our patients. So let's see, what is BHRT or Bioidentical Hormone Replacement Therapy, and how's it different from traditional hormone therapy?
Yeah. I'll talk about that. I always like to start with, you know, when we use the word synthetic, if you're really going to be technical about it, bioidentical hormones are synthetic. Anything that's manufactured in a plant, in a laboratory, is going to be synthesized into something. Terminology-wise, colloquially, we use synthetic hormones versus bioidentical, although they're both synthesized from something. The standard hormone replacement therapy is kind of the verbiage that I've used, is synthetic chemicals that are developed to imitate the natural form. So that becomes a synthetic hormone. And they are close enough to fit in the receptor and offset some of the symptoms. And that is really usually hot flashes, vaginal dryness, mood swings, night sweats. Those are the things that are most typically found that they help with. But they don't necessarily completely fit and activate that cell like a natural hormone will. So bioidentical hormones are synthesized from usually plant sources. Yams, soy are the two most common, and they're able to pull out the molecule and then make that look like natural estrogen. So to the body, it says, oh, that key and lock fits perfect. And now it acts exactly like the hormones that my ovaries used to make, and the body acts as if it's just gotten its life back. So the terminology is really kind of part of it, but synthetic is usually Premarin and the medroxyprogesterone, and then in a bioidentical form, we use 17-beta estradiol, which is our form that we make, and natural progesterone. And those are very different on how they react in the body.
Can a woman with a history of breast cancer use BHRT safely? I think, that's something where we're not going to tell you, yes across the board. I think that's a conversation that each woman needs to have with their oncologist. But I also think it's important to seek out oncologists who understand the whole issue with estrogen and progesterone, progestin, and understand the differences in I think that's really an individual conversation that people need to have with their oncologist. But you also need to find somebody in terms of an oncologist who really understands.
That's tough.
And that's not easy.
I always like to add and remind people, a really solid study came out a number of years ago, but it showed that there was about a 17-year gap between solid evidence being in the literature, starting to be followed, and your primary care, even your specialist, using that on a regular basis. That's a long time for a lot of people until finally it becomes more commonplace. Right. So to your point, you really need somebody who is up to date with the literature, who is more open-minded about what else are you doing. If I meet a woman who has had a breast cancer, and some of these women had their breast cancer in their 40s, and they're seeing me at 60, and they're miserable. There's a quality of life component we have to talk about, but also what else are you doing to prevent you from getting any cancer? If you're living a very healthy lifestyle, and that is on and on and on, and you are doing proactive things, that's a little different than, hey, can I just go on this and live my life as an obese woman who's still going to eat an American diet and not go out and exercise, and I have bad relationships. I'm a lot more nervous for that person than the woman who's really doing all these things for her health.
Well, and people talk about genes, so say you have the BRCA, 1 or 2 gene, or you're predisposed to any cancer, much less breast cancer. People talk about them as being, yes, you have the genes, you might have an increased potential, but it's really the epigenetics, or what is it that's going to turn these genes on and off, and that's actually a bigger factor than just having the genes, is what are these things like Susan is talking about that turn the genes on and off. Right. Any woman that's interested in this whole issue with breast cancer and estrogen, this book, by Dr. Avram Blooming and Carol Tavers, who's a PhD in psychology, wrote this book together. It really goes through a lot of the studies and the reasons why we're talking about estrogen. We don't consider estrogen as something that causes breast cancer, but in this book, to your point, in terms of looking at, women that have had breast cancer, we talk about estrogen and progesterone and all these receptor positive situations. In this book, it's interesting where they say, people tend to think, oh, you're estrogen receptor positive, so that means that estrogen is causing or feeding your breast cancer. And that's not necessarily the case, meaning if you have these receptors on your cells, that's normal, right? It's normal to have estrogen and progesterone receptors on most of the cells in your body, and that's a normal expression. So the cells actually that don't have these receptors on their surface are often the ones that are proliferating the fastest and aren't the normal cells because they don't have the receptors on their surface. A little bit more nuanced in terms of, which are the good cells and which are the bad cells. One of the things that they talk about in this book is that estrogen and progesterone receptor positive, that's normal behavior of a cell, and those aren't the ones that are proliferating. Just because they're a fireman at the fire doesn't mean they started the fire. They're there to fight the fire. So we have to look into some of that a little bit in more of a nuanced way. Yeah. Let's see, does progesterone protect against breast cancer risks associated with estrogen? So that's sort of a leading question, meaning estrogen doesn't cause breast cancer, and just is progesterone protective? Well, it certainly protects the uterus.
Yeah, but it also does balance estrogen. So that's, I think, where some of this confusion may come from is, again, estrogen acts as a growth hormone. I mean, women know this. They get a period and their breasts may get engorged, they can get pregnant and they build a baby. That's estrogen. Progesterone does help to balance that. And so progesterone can be more of the calming hormone, but also kind of offset some of that proliferation. And so preventive, I would say yes, because it, again, is balancing this hormone that can cause acceleration of a growth. Progesterone is absolutely necessary to protect the uterus when we're in hormone replacement therapy. But I think we really need to start looking at our peri and our premenopausal women. I was taught a decade ago they deserve their progesterone even earlier because we have these fluctuations of estrogen. That's why we don't feel so great during a lot of times before we go into menopause. We may have daily fluctuations of estrogen. And then you might have periods or sections of time where you're not putting out very much estrogen, and then others where it's a high percentage. So we lose our progesterone typically a lot sooner than we do our estrogen. So you may have a lot more kind of what we term estrogen dominance, and the progesterone can really help to off balance that. And that's probably what we need to start initiating even sooner for our girls is, consider these women may have premenopause in their late 20s and 30s. That's not just life's getting harder, that's you're really losing some of these hormones. They're not always easy to test because they are so off the charts erratic.
Well, and I think you really need to check with lab tests. Just because you're still menstruating doesn't mean your hormone situation is good.
True.
So if you think about when they talk about osteoporosis or losing bone density, your bone density often will start to drop in your late 20s and early 30s. And why is that? Well, you're starting to lose some of your hormones in your late 20s and early 30s. So I think that's something, without actually doing a lab test to check your hormones, it's not enough for somebody to ask you, are you still menstruating? It's, you don't lose your hormones all of a sudden when you go through, when you stop your periods. Things could be imbalanced earlier.
Right.
Another question, what monitoring or testing should be done for women on BHRT?
What I have found is this notion that just putting somebody on HRT is good enough. We're just going to put a patch on you. We use pellet therapy in our practice, patches, troches on occasion. The most conventional is just putting a patch onto a woman and their symptoms feel better and they're done. The problem with that, and why I think testing is so important in menopause, is if you're not getting enough estrogen, you're not going to get the benefits that we're talking about. You're not going to get as much cardioprotectiveness. Being on HRT can reduce your risk of an MI, a heart attack, by 50%, but not if you're sitting at a level of 20. Your hot flashes may be better, you don't have any vaginal dryness, but you're not getting therapeutic levels. So that was something that I learned when I really came into this venue versus when I was treated for menopause and placed on a patch. My levels were at about 30, and if I had stayed there for the rest of my life, I could end up with a broken hip, heart disease, and dementia, even though I'm on hormones. So I think monitoring at least once a year. I'm starting to think that even maybe twice a year for some things may be better. I am really a big advocate of we need to have these levels at the levels you deserve. You know, when we're menstruating, they go anywhere from a super low of 19, that's kind of silly, but they could go up to 300 and nobody's checking levels then. But yet we go into menopause and it's like, oh, just a little bit for you. So we really need to check these levels to make sure you're getting adequate treatment. And the same with progesterone. Progesterone should be somewhere over 10 for good health.
There are still people that do hormone replacement therapy that say you don't need progesterone if you don't have a uterus. And as Susan mentioned, you need it to balance the effects of estrogen regardless of whether you have a uterus or not. Just because you have a uterus doesn't mean you don't need the progesterone. And it can help with sleep and mood and so many other things.
And brain. And it does help with atherosclerosis. Can help to prevent some of that plaque formation. Estrogen can actually reverse plaque in arteries, which is pretty cool to see. But to your point, I think many women are deprived of progesterone because they don't have a uterus, which means they won't bleed on hormone replacement therapy.
Right. Women need testosterone. You know,
Absolutely.
we don't need as much as men do, but it's important to have the testosterone, again, for bone, brain, heart health. I mean, estrogen and testosterone receptors are probably on greater than 80 to 90% of the cells in your body, so that's how much you need those things. And in terms of...
we feel better.
Yes.
We have a better, intimacy. We actually get a more comfortable libido, satisfaction. That's something that a lot of women have really missed out on, and we've just kind of let them do that. And that's not what their partners are looking at, and that's a big intimacy factor for a lot of couples. So testosterone can really be powerful from an emotional perspective, but also really from a health perspective as well.
And then the usual breast cancer screening, getting your mammograms or whatever
Or
studies that
ultrasound
you're
or mammogram.
whatever you're doing. You still need to keep up with those things.
I think the real bottom line is we can't be afraid of a natural hormone that we were given, and that when you really look at the whole progression of life, this is how I look at it. Without sounding too crass, we're here to procreate. I mean, that's kind of biology. And so we get to a point where we are no longer able to do that, and that's kind of the trend to, okay, you're on the way out. That's not modern world at all. Many of us are working in our 60s, 70s. There's people that are still working in their 80s. If nothing else, they still want to have a good quality of life. There's really a health span and a lifespan. And in modern medicine, we're really, really good at lifespan. We can keep us alive a long time. What's my quality of life? And so I really love that we are finally getting into an area where we can say, wait a minute, just because I lost that ability doesn't mean it's time for me to move on. What can I do to offset that so that my quality of life matches my life expectancy? And I think we're finally getting there, but it's really movements like this that we keep educating patients, because they may have to educate their providers and take a stand when they do talk to their providers. That's really my goal, is to help women and men with their hormones understand this is your decision. The days of the white coat, the stethoscope, this is what you're doing, they have to be offset with what makes sense to the consumer, because this is a consumer product, really. And the more I can help people understand their health, their wellness, and that this is a big part of it, they become more invested in this, and they feel more comfortable saying to their provider, who may say, I don't think you should do that, well, this is why I am doing this. And I'm really happy to see that's finally happening.
Right, and I think we still get patients that come in and say, it's natural to lose your hormones and get old. I want to grow old naturally. Well, let's think about what the reality of that is. So first of all, before the advent of antibiotics, we didn't live beyond our 40s and 50s. People didn't live to be 70, 80, 90. So part of that meant that you didn't live long enough to develop cancer, dementia, fractures, heart disease, and all of those problems. Plus, as Susan mentioned, with all the environmental issues, we are getting those things at a higher rate. And so let's think about what growing old naturally means without your hormones. It means heart disease, cancer, dementia, fractures, and all of those things. So when we talk about quality of life, you know, if you decide that you don't want to have your hormones replaced, you could be sitting in a corner in a wheelchair with a hip fracture, drooling and not knowing your name.
Right.
And so, I mean, it's one thing in terms of, well, who's going to be responsible for you at that point? I mean, if you don't mind drooling with a hip fracture in a corner in a wheelchair, somebody's taking care of you.
Right.
So is that society? Is that your family? I mean, who you become the ward to who,
Right.
you know? And so if you want to maintain a good quality of life, and in my mind, it's no different than when you lose, you know, you can't read the newspaper and you wear glasses. Well,
Right.
if you want to grow old naturally, then don't get your bifocals. I mean, you know, that's part and parcel
Exactly.
of growing old naturally. And so that's something where, you know, we talk about squaring off the curve. So good or bad in this country, as Susan mentioned, we can keep you alive for a very long time, but you're going to get the dwindles, I call it. You know, you're going to be tortured by the U.S. healthcare system,
Right.
financially, physically, mentally, and whatever. But when we talk about squaring off the curve, basically you don't want to get the dwindles and see this slow decline in your quality of life.
Mm-hmm.
You want to be really healthy, feel great, and not wake up one day,
Right.
you know. So how do we do that? You know, how do we improve the quality of life and help support you, you know, financially in terms of not needing to be in the ICU or in a home for the last part of your life. And so, you know, what we're proposing is that, you know, proper hormone replacement is really key to that.
Adding on to that, just this quality of life, some of it is just urinary tract infections, stress incontinence. These are urinary tract infection, of course, can land you in an ICU and sepsis. It can also cause transient cognitive decline, but also you're really compromising a woman's life if she's got significant stress incontinence. Some women don't leave the house, or they just buy a lot of Depends. I mean, this is silly that everybody's in a Depends these days and they fit all the sizes. And no, that's a serious social issue because you might smell a little bit, you're uncomfortable that you don't want to wear a pad. So those are these little things that we're like, oh, that's not that bad. No, that's lack of estrogen. You know, those tissues change. And so there's all these nuances. Hip bursitis and frozen shoulder, much higher in a woman without estrogen. You put a woman on estrogen, she gets her mobility back. So there's these little nuances that we think of, the big things, which we need to, because we do die from heart disease first. We get more dementia and we break more hips. But just even the nuance of, I want nicer skin. I'd like my hair to look good. You know, I want to be able to walk without pain in my hips. That's a lot of lack of estrogen. And we just kind of blow that off like, well, you're getting older. Yeah, say that to a 56-year-old. They don't like hearing that yet. You know, you might be able to say that to an 85-year-old, but you know, we've really changed the course of what women are expecting. And so I really think we need to understand the bigger picture, that it's not just these couple of things. We'll get rid of your hot flashes. This is a big quality of life and definitely better living through hormones.
So, you know, find a provider, talk to your provider, find someone that's educated and knowledgeable.
And keep learning on your own. Keep your mind open and keep learning. Mm-hmm. And
because unfortunately these days you have to be an educated healthcare consumer, whether you like it or not.
Yeah.
So we can help you in terms of finding articles or books or resources
Absolutely.
to educate yourself. So, you know, we think that that's really important in terms of being an advocate for yourself.
yeah.
Well, thanks so
Thank
much for
you.
listening in.